So for our contributors for this lecture, I want to thank a few people. First of all, Dr. Robert Martin, who is our program director at Ascension St. Vincent's. And then I'd also like to thank Stefan Esser, who is on our faculty as a PM in our sports med and has taught me so much about ultrasound evaluation or musculoskeletal ultrasound throughout the year. I'd also like to thank Dr. Jason Reed, who is one of our sports medicine, primary care sports medicine docs, who also sees a lot of pediatrics. Dr. Mazzella, who is with us with interventional spine, interventional radiology, excuse me. And then I've got two residents that also contributed to this project who are also interested in sports medicine fellowship here in the future. So a big shout out and thank you to Dr. Shannon Phillips and Dr. Kara Parker for helping me out with this presentation. So for my disclosures, I don't have any disclosures to identify for this lecture. So let's go over some of the objectives. Basically, when it comes to residents using the ultrasound, I really like them to use it as a tool, basically just to fortify and learn their anatomy. And then once I feel like they're comfortable with that, we kind of move toward being able to consistently identify these structures. And then really, as their skills become more advanced, start to learn how to employ a protocol. And most importantly, figure out how to do it the same way every time so that it's reproducible. So for our objectives, we're going to review the relevant anatomy of the anterior hip. We're going to review a relevant patient case that we were able to see this year, as well as some of the symptomatology of anterior hip pathology in our young athletes. We're going to review a ultrasound protocol for a diagnostic ultrasound of the anterior hip. We're going to review some of the sonographic images that we were able to collect. And then we're going to review, in summary, the entire case ultrasound report at the end of our presentation here. So this was a 17-year-old female who presented to our clinic with a 6-month history of pain at the front of the hip. She denied any recent trauma. She rated the pain as a 0 out of 10. At rest, it was up to a 7 out of 10 with provocative maneuvers. Our transitions from laying to standing, bringing the leg across her body were really the main triggers for her pain. Her associated symptoms included a painful and a loudly audible pop in the front of the hip that relieved her pain temporarily. She denied any catching or locking of the hip joint. She denied any sensation of instability or weakness. The hip was not giving way when she was walking or running. She denied any radiating pains. She denied any numbness or tingling down the legs. She denied any pelvic pain, and there was no association of this pain with her menstrual cycle. And there was no congenital or no history of hip dysplasia, no history of previous hip surgery or injection. So always important to review our differential, especially intra and extra articular causes of hip snapping. So keeping a broad differential for this, especially in active young athletes, is particularly important. And we also want to make sure we recognize the red flags that are associated with this complaint. So when we're forming a differential, so our limitations in range of motion would be important to recognize as a red flag, or asymmetry of the range of motion in particular. Hip catching and locking or intermittent immobilization of the joint is important to recognize. Fevers, night sweats, weight loss, limping, those kinds of things are things that you want to make sure that you're ruling out or taking a look at. So first off on our list for this anterior snapping pain, hip labrum pathology is probably number one in a young athlete that you want to make sure that you recognize early. A hip joint loose body would be a little bit lower on the differential, but possible, and then even lower would probably be a synovial chondromatosis. FAI, or femoroacetabular impingement, is a particularly important one to recognize. It's a little more common. The anterior snapping hip syndrome, which we're going to talk about and we're going to view some images of. And then the lateral snapping hip syndrome as well can also produce some popping that patients will sometimes poorly localize, but can also give similar symptoms. The iliopsoas bursitis is also a possible cause of this problem, as well as iliopsoas tendinopathy and tendinitis. So this was our differential just by hearing the patient history. So this is the equipment that we were able to use. We were fortunate enough to be able to utilize the GE Logic E9 ultrasound system for the exam. We found that the linear probe worked really well for the superficial structures that were overlying the pelvis. We were able to use this for the majority of the exam. It is important, however, especially when it comes to the hip, to recognize that you may require a curvilinear probe and or lower frequencies to evaluate the deeper structures like the hip joint recess, as well as the joint, or as well as the labrum as well. It's important to keep that in mind when it comes to your equipment choice. So let's go over some of the relevant bony landmarks. So just of our pelvis here, so the pelvic crest right along here, the ASIS is important to recognize. Moving inferiorly, the AIIS, and then our femoral head as well as our femoral neck here. And then our greater trochanter as well as our lesser trochanter here inferiorly. And it's important when you're approaching the ultrasound just to kind of visualize where you think these structures are most likely to be on your patient. So, and then our image on the right here was a nice illustration I was able to find of the cup-shaped fibrocartilage ring, also known as the hip labrum. So this stabilizes the femoral head within the acetabulum and also serves as a shock absorber. So for our complete examination of the anterior hip, this was our ultrasound protocol that we were able to procure and go through in its entirety. So these are highlighted in yellow as the specific evaluations for the anterior hip joint. So anterior hip, we're going to evaluate the joint first. We're going to look for effusion. We're going to look for any evidence of synovitis or any capsular thickening. We're also going to look and scan for any cortical irregularities of the hip joint. We're going to evaluate the anterior labrum to a limited extent, the iliopsoas tendon in short and long axis, distal to proximal. And then we're going to also examine for any evidence of bursitis or fluid collection, and then also evaluating for any dynamic snapping if the patient is complaining of this, which our patient was. The rectus femoris, direct and the indirect heads, our sartorius muscle and the attachment, and then our dynamic examination, like we mentioned, if they are complaining of those symptoms of internal, external snapping. There are protocols for the adductors, lateral hip, and the hamstrings, but we are doing a we are doing an examination of the anterior hip, so we will be omitting these areas. There are the anatomy in these areas. So as we get started, the first image, as I tell the residents when they're first getting started, is just keep it simple. So find the large bones. If you're lost and you don't know where you're at, find the large bones and then trace them to your target. So they tend to do better with the hip basically just by finding the femur and short axis view and then moving proximally until the femur kind of flattens out and becomes, so that flattening that you'll see as you move proximally is going to be the formation of the lesser and the greater trochanter. So once you see this, the probe should be shifted into the oblique and sagittal plane for this visualization that we see here in this image. So here we can evaluate our joint space, which is here where my pointer is at, as well as the acetabulum here. We can also note the head of the femur, and we're going to scan along the head of the femur for any cortical irregularities. And then the anterior joint capsule, which is here in this joint recess, which is going to begin up here superiorly at the labrum. It's going to extend downward, kind of overlapping, as you can see in this diagram, and it's going to insert at the intertrochanteric line. So this joint capsule is an important area to examine in detail. Normally, the anterior joint capsule should be around 2 to 3 millimeters thick, and usually does not have any effusion present. So more than 2 millimeters of thickness of this capsule or presence of an effusion in this joint, we would consider abnormal and we would report on, which we did not see in this patient. So optimal visualization of this joint recess is going to be obtained mainly by keeping the probe as close to perpendicular on the femoral neck as possible. As we move along, visualization of our fibrocartilage labrum. This was a nice image we were able to obtain. It's sometimes possible depending on the technique and as well as the quality of your ultrasound system. So our labrum, as we recall, is a triangular hyperechoic structure at this angle. And we're going to basically look for areas of hypoechogenicity within the labrum. So this is the outline of the labrum here. So we're basically looking for areas of hypoechogenicity that might suggest any tearing or fraying or any free fragments. We're also going to be looking for any evidence of calcification within the labrum, which can sometimes be seen in cases of femoroacetabular impingement. So as we translate the probe back and forth over the labrum, We did not see any focal abnormalities within the anterior labrum, but it's important to note here, the examination of the labrum is limited because we're unable to visualize the posterior portion based on our location of our probe here, and just based on the anatomy in general, the anterior labrum is really all that you can identify or all that you can evaluate. So that being said, if you have a high clinical suspicion of labral pathology in a young athlete, an MRI is going to be your study of choice. So before we go to our next ultrasound image, let's discuss some of the anatomy of the iliopsoas complex just to get everybody familiar. So here is the iliacus muscle. So this is a flat triangular muscle that arises basically along broad attachments along the iliac wing. So it's fan-shaped at its origin, and then it tapers and it's going to descend and it's going to insert into the lateral side of the psoas muscle, the psoas tendon, excuse me. And then it's going to move down to the lesser trochanter of the femur. The psoas major, which is here, arises from the transverse processes of our lumbar vertebrae, and it also arises from the intervertebral discs and then the adjacent vertebral margins from T12 to L5. So this muscle, the psoas major, as well as the iliacus muscle here, are going to merge at the level of the L5 to S2 vertebrae, and then they're going to dive underneath the inguinal ligament to form the common unit, the iliopsoas muscle. And then this is going to form a common tendon, also known as the common iliopsoas tendon, which is going to travel inferiorly and insert onto the lesser trochanter. These muscles primarily are hip flexors. They do assist to some extent with lateral flexion of the vertebral column, but mainly it's the big, powerful hip flexion motion. Of note, this bursa, the iliopsoas bursa, is the largest bursa in the human body, and should be basically invisible in a normal anatomic or a normal ultrasound scan. This was a nice highlighted x-ray that I was able to find of the bony landmarks that we mentioned in the pelvis, as well as the muscular attachments. So always good to review your anatomy of these. So this is to visualize this area. Our probe should be placed basically in the orientation shown here below. Basically placed in a transverse plane over the femoral head, and then we're going to move just superiorly to expose this view. So it's important to note the fibers of the iliacus muscle, the medial fibers of the iliacus muscle are really just superior to the iliopsoas tendon here. So tendon here, medial fibers of the iliacus. And it's also important to notice the location of the femoral artery and to visualize or keep that structure in visualization, especially if an injection to the tendon sheath is to be performed. So this femoral artery here, you're always going to want to keep in view anytime you're performing a procedure. So this view is basically our home base for the evaluation of the snapping of the anterior hip. So although our patient had some symptomatology that was consistent with the anterior snapping hip, we were really kind of unable to reproduce this in the patient. So during the exam, even though we were using Faber positioning, she really wasn't able to recreate her symptoms. So we weren't able to visualize tendon snapping, unfortunately. However, I do have a YouTube video that I was able to find that's a pretty good example of this. So I'll go ahead and play that. So dynamic scanning is usually going to be performed with the patient basically placed into that Faber positioning. And then you're going to try to keep the probe as stable as you can. It's quite difficult, but keeping the probe as stable as you can while the leg is quickly straightened. So normally the tendon fibers are going to glide gracefully over the pelvic brim during this Faber positioning, and then they're going to return to the neutral position. And anterior hip snapping, as we see here, it can be caused by a couple things. So these tendon fibers can be caught on the iliopectineal eminence and then popping across, or as we see here, the medial fibers of the iliacus muscle can get trapped basically underneath the tendon. And this creates a lot of tension on this tendon as the leg is straightened. So during this maneuver, if you're really careful, you can see that sudden rapid medial rotational movement, which is what we see here in this video. So medial rotational movement, snapping of the iliopsoas tendon as it snaps back onto the pelvic brim and creates that loud sound and sometimes pain for the patient. So this is a nice skill to learn if you can practice it. because dynamic hip ultrasonography is basically the gold standard for the diagnosis of anterior snapping hip. So moving on, our iliopsoas complex as well as the iliopsoas tendon really should be visualized in a long axis view to complete this portion of the examination. This is going to be accomplished by rotating our probe 90 degrees from our previous orientation into a longitudinal plane directly over the tendon as it traverses the joint space. And then we're really going to just follow it down to the lesser trochanter to give us the view that we see here. So it's of a particular importance just to look for the presence of tendon bursal fluid, any thickening of the tendon, as well as any evidence of tendinosis, which would manifest basically as thickening and hypoechogenicity or hypoechogenicity of the tendon itself. So fortunately for our patient, these tendon fibers are nicely tightly packed, and there was no fluid collection and no hypoechogenicity that might suggest tendinosis. So before our next ultrasound image, let's just take a couple minutes to discuss some more anatomy, namely of the rectus femoris muscle. So rectus femoris is described as the kicking muscle. It's commonly injured in adolescent athletes that participate in kicking sports. If they have open growth plates, they can also develop a traction apophysitis at the attachment at the AIS. Importance of understanding the two heads of the muscle as well as their anatomic orientation is going to be key to finding these structures, just because the indirect head is notoriously kind of difficult to visualize or technically difficult skilled. This illustration does a really nice job of depicting the changes seen within the muscle as the tendon heads develop. So we're going to review those findings in our ultrasound images. Okay, so to find our AIIS, and just in reference to the probe location for visualization of our iliopsoas tendon, so we're going to stay in a transverse plane. I'm going to move slightly superiorly and slightly laterally just to find our next landmark, which is our AIIS. So in this image, and you can see the orientation of our probe here, you can just begin to visualize the origin of the direct head of the rectus femoris here, which is this bird's beak appearing structure. And we're going to note the medial orientation of the iliopsoas complex here. So moving right along, once this landmark is going to be identified, we're going to basically holding this AIIS in view, we're going to rotate our probe just into the longitudinal plane to visualize this direct head of the rectus femoris tendon. So this is we're going to visualize it along its length and just scan across back and forth for any abnormalities. So in our patient, we did note a group of calcifications that were just at the enthesis or the tendon attachment. These calcifications this area was non-tender to palpation. It was also non-tender with activation of the rectus femoris muscle. So rectus femoris enthesis calcifications have been documented. I've seen a few case reports, but fortunately for her, no evidence of tendinosis was present, and this was non-tender with activation of the muscle. So we felt this finding was likely a sequelae from an old injury. And then I just saved a couple more images of these calcifications. So we were able to get really good visualization of these. It's another nice view of them there. Okay, so moving on to expose our indirect tendon of the rectus femoris, the probe is then going to be translated just laterally towards the greater trochanter. The indirect head of the rectus femoris is only partially visualized in our view here, unfortunately. These are some of the fibers that we were able to catch. And this is just because the tendon does basically a really sharp turn as it traverses the lateral ridge of the capsule of the hip joint and then kind of sweeps around behind. So this view, or the classic view of this tendon in long axis, the proximal portion should appear hypoechoic and the distal portion should appear hyperechoic, which is a classic example of anisotropy, just because as those tendon fibers change their angle moving around the corner, you lose sight of some of the tendon fibers. Unfortunately, we were unable to really see a clear demarcation there just because of this patient's anatomy and the sharp turn. So to evaluate our rectus femoris in the short axis, we will scan distally in the transverse plane from where we're at, basically from where the rectus femoris direct and the indirect heads were, and then you can trace those inferiorly to where they join the body of the muscle, or you can start in the middle of the muscle in the thigh and then move superiorly. So for our exam, this image, we started in the proximal thigh and we moved superiorly to trace the muscle upwards. So not only was the rectus femoris unique in that it's a biarthrodial muscle, meaning that it crosses two joints, but it also has a pretty unique ultrasound profile when we're scanning in the transverse plane and then we're following it. So we were able to visualize this central aponeurosis here, which is this hyperechoic area in the middle of the muscle. This was particularly a high yield area for muscular injury. So patients who are complaining of symptoms in this area, this is a good spot to look for tears. And you're going to note as we go through the next couple images, as we scan proximally, the fibers of the direct tendon are going to flatten out and they're just going to become superficial within the muscle. So as we scroll upward, our central aponeurosis gets a little bit more tightly packed. This is our vastus intermedius here, and then the femur just underneath. And then you'll note the flattening of the tendon at this point is the direct tendon here. So this hyperechoic structure as we move more superiorly. So fortunately for our patient, we didn't see any fluid collections, any hypoechogenic areas that would suggest muscle tearing. So for our next landmark, we're going to move the probe from this location. We're going to move superiorly and we're going to stay in the transverse plane until we can find kind of the ridge of the iliac crest. So the ASIS is going to be readily identified as this pretty large prominence. It's going to be just superior to the AIIS as we scan superiorly. So this is another site where you can have traction apophysitis in adolescents, although it's a little bit less common just because the rate of injury of the sartorius muscle is kind of low. And we're going to note the nice demarcation of the TFL laterally here. So this is a nice divider. And the sartorius tendon attachment here on the medial side. And then we're also going to note the medial orientation of the iliopsoas complex here. Fortunately for our patient, no calcifications, no thickening was noted at the attachment of the sartorius. And then to complete our exam, we're going to move and look at the vascular bundle. So we're going to move to the acetabular rim, and we're going to stay in the transverse plane as our probe orienter shows us here. And we can just basically move the probe medially, and we're going to find this bundle deep to the inguinal ligament, and it's going to be just overlying the rim of the pubis, which we can see here. So fortunately for our patient, no aneurysms or masses were appreciated, and the femoral nerve was normal in appearance, so we didn't see any cystic changes within the nerve itself. No evidence of nerve sheath tumor, so important to evaluate these structures, and these were normal, which was good. And then to complete our ultrasound evaluation, so just to review our findings, we'll go over quickly. Our hip joint was normal in appearance, so we had no evidence of effusion or synovial hypertrophy. No femoral or acetabular cortical irregularities were noted. And we can say this was a limited evaluation of the anterior labrum, but it was normal. No evidence of iliopsoas bursal distension or tendinosis. We didn't note any snapping. But the patient, again, was unable to kind of reproduce the snapping for us during our dynamic imaging. We did see a group of discrete calcifications that were present at the insertion of the direct tendon of the rectus femoris. But there was no evidence of tendinosis or fluid collection. The indirect tendon of the rectus femoris was only partially visualized, but the areas that we were able to visualize were negative for any effusion or for any thickening. Our attachment of the sartorius at the ASIS was unremarkable, and then to complete our exam, the neurovascular bundle was unremarkable. So we had no masses appreciated there. So that completes kind of our tour through the anterior hip. I just want to thank everybody for attending, and I hope you got something out of it. So if you have any questions for me, please feel free to shoot me an email, drstephenarnold@ascension.org. You can shoot me an email there. I'm also on AMSSM Collaborate. So if you have anything, feel free to send me a message on there as well. Thank you so much.